Okay, we'll get started. Okay, guys in the back, if you want to we'll get going so we can get out of here. We shouldn't be here all 4 hours. This is endo, it zips through fast. We're on the last unit, made it to the last module. It's endo and reproductive. It's basically all hormones from here on out. So if you like to whiteboard and draw these things out, get used to drawing them out because you're going to have to know the pathways and the negative feedbacks for all the hormones we're going to go through. So I'll tell you, okay, this is what you have to know as we go through each section. So we're on the last little bit, endocrine, and then here's your objectives for today that we'll get through the lecture. So hormones in general are just chemicals made by the body and they act as a messenger. They travel in the blood. That's the important thing about endocrine. It's in the blood. And it's going to have a specific effect on a target organ or tissue. It's going to have something to do with another organ downstream. I mentioned this before. When you're talking about endocrine, look at it is, do we have, especially when you get to the patho part, what happens when you have too much of this stuff? What happens when you have too little of the stuff? Growth hormone. If you have way too much growth hormone, you're going to be huge. You're going to be gigantic. And there's gigantism or acromegaly, depending on how old you are, but basically you're going to be growing like crazy. If you have inefficient or insufficient growth hormone, then you're going to be very small because you don't have enough growth hormone to make you grow fast. So all these hormones, either you have too much or too little, what's the effect going to be? Some diseases like cancer, atherosclerosis, they're not hormonal imbalances, but when you have these things, they cause hormonal imbalances. Communication system. We did neural already. Rapid transfer of information, electrical signals, and neurotransmitters are the chemical that we use for neural communication. From one neuron to the next, it's going to be a neurotransmitter. It is fast. Endocrine, chemical transmitter in the blood to a distant site. This is slow. Takes a while for this to have an effect. You got to release the hormone. It's got to get to its target tissue. Then it has an effect later on. Neuroendocrine. We are combining to have a neural input to cause release of a hormone. Is this going to be fast or slow? Fast. Faster than normal endocrine because you're having a neural input telling it to release things. Where have we learned so far of these neural inputs? There's two of them that we know so far, which I went through already. Adrenal medulla, remember fight or flight, those sympathetic nerves go right into the medulla to tell it to release epinephrine and norepinephrine. If it wasn't neurally mediated, it would be a very slow response and your fight or flight would take a few minutes to kick in. Not now when you needed to run away from a bear. So that's what's going on with neuroendocrine. So ADH in the posterior pituitary, all the hormones in the posterior pituitary, there are only two of them, are all neurally mediated. ADH, what's the other one in the posterior pituitary? Oxytocin, so the love hormone. Those are neurally mediated release. Everything else in the anterior pituitary is all hormonally released. It's all endocrine. We have paracrine, and these are into the surrounding interstitial fluid. Histamine, we learned about that. All those, remember the histamine gets released, acts right on that gastric cell. That's a paracrine. And we have autocrine, which is self-regulating. It regulates itself. So whatever it releases is going to come right back and target that same cell to cause a release of a hormone. So these are just other ways of looking at it. Here's your neural. There's your endocrine. It's got to go into the blood. Here's our neuroendocrine. It releases it right into the blood from the neural input, and it goes right into the blood. And then we have our paracrine cells next to it, and autocrine releases and it targets itself again. So those are the different ways our body communicates within the body. Classes of hormones. This is where we get to the stuff you have to start remembering these things now. Peptides, amines, and steroids. Those are the three classes of hormones that we have in our body. The peptides, that is the largest group, synthesized in the rough endoplasmic reticulum, stored as active hormones. Okay, so these are ready to go. When they get stored in a vesicle, they get stored in these intercellular vesicles. Vesicles until a stimulus triggers the secretion. So with these peptide hormones, they're sitting around and waiting. They're active. They're in vesicles ready to go. When a stimulus comes in and tells it to release it, then they release those right into the bloodstream. The peptides are generally water soluble, so they're going to dissolve in the plasma. They can go around. So they don't require a carrier in the blood. Because they're water soluble, they can dissolve right in the blood and go where they had to go. So those are the peptides. The next group are the amines. So dopamine is an amine group, and so is epinephrine and norepinephrine. Thyroid hormones are also considered amines. Thyroid hormone acts differently. We'll get to that a little bit later on. It's a little special. They're stored in, again, vesicles waiting to be released from a stimulus. The catecholamines do not require carriers in the blood, but the thyroid hormones do because they have very poor water solubility. So remember these things. If they have poor water solubility, they're lipid chemicals. They can't dissolve in the blood. They need a carrier protein to bind to. So a lot of these amines, like thyroid, requires a carrier protein to get around the body. So these are amines. The last group are the steroids. All steroids are synthesized from cholesterol. Okay, so you need cholesterol in your body. You have to eat cholesterol. Your liver will make it if you don't get enough of it in your diet. But we need cholesterol. It helps with cell membrane rigidity, muscle growth, a lot of other things going on. Your example of the steroids: cortisol, aldosterone, testosterone, estrogen, and your progesterone. These are all steroids. That's why you have non-steroidal anti-inflammatory drugs, because these steroids are also anti-inflammatory. You don't want to be on steroids for long-term use, and we'll go over that why later on. Steroids are not stored in vesicles. They rapidly diffuse out of the cell once they are synthesized. So once these things are made, these steroids, once they're made, they're packaged and they're gone. They don't wait. So they're kind of like on demand. When we need more steroid, we make it. And it gets out of the cell due to high lipid solubility. So it can get through the cell membrane easily. It doesn't require a protein or anything because it's lipid soluble. But because they are lipid soluble, they do require carriers to get around the blood. Okay, so those are the three different classes of hormones: peptides, amines, and steroids. So with this one, the top part is just dealing with peptides and amines. So the top peptides and amines. So how do they work? How do they make? So step one is synthesis and storage. So how do we make these peptides and amine hormones? So the first thing that happens in the yellow, this is the nucleus. And we have to make the protein, so we have to do our DNA to messenger RNA. Okay, RNA makes the proteins, so they got to do it. So the nucleus starts the process. Then we get to the ribosomes. And when they're in the ribosomes, they're considered a pro hormone. Pro. How many times do you think this has to get cut to be the active hormone? Twice. So in the ribosomes, it's a pro hormone. As this hormone starts to mature, it goes into the endoplasmic reticulum, and it becomes, at this point, a pro hormone. Cleaved it once from pre-pro, now it's a pro hormone, ready to go for the next step. After that, then it goes to Golgi apparatus. And that's where it starts to package them into the vesicles. And now, at this point, we have our fully fledged peptide hormone that gets stored and ready to go whenever it needs to be released. Next step, transport. How do these things get around? Okay, once they're in the blood, do these require carrier proteins? Nope. So in the blood, the entire peptide hormone just floats around. We're using peptide hormones as an example. This is all the peptide hormones all follow the same pattern and procedure to get packaged and ready to go. So now we have these peptide and amine hormones in the blood, and they're going to have their binding effects. So this is our cell. There's our nucleus. What these peptides do, they're going to bind to a surface receptor. It just binds to the surface receptor of the cell, and then it has its effect inside that target cell. So peptides and amines just bind to a surface receptor. Let me put that in. Okay? And that's all they do. So when we learn about like insulin go to the target the muscle and have it bind to the surface receptor and tell that muscle to open up your gates for glucose. We're ready to start absorbing some. So those are your peptides and your amines. The bottom section is dealing with steroids because they behave differently. So the important thing about synthesis, on demand. So all steroids are made on demand. If you need the steroid, you make it, and as soon as it's made, it gets released. So on demand, once they're made, they're released into the bloodstream. What is the common precursor to all steroids? Cholesterol. So the cholesterol is going to go to two different areas. It's going to go to the gonads. Okay, and what are the two sex organs that produce steroids? testes and ovaries. And they'll have their effects there. Cholesterol also is going to go to the adrenal medulla, where the other steroids are made. So we go to the adrenal medulla, and we're going to make corticosteroids. I'm having a blank. Yeah, mineralocorticoids. So corticosteroids, mineralocorticoids, and the last thing, the adrenal medulla, or sorry, not the medulla, it's going to be the cortex, I'm sorry, is androgens. So erase medulla, it's the cortex. Okay, corticosteroids, mineralocorticoids, and androgens are the three things that the adrenal cortex makes for steroids. And testes and ovaries. Majority, we're going to bind with a carrier protein. So we have our steroid here, and they're going to be bound in the blood to a carrier protein. Why do they need a carrier protein? Lipid soluble. They can't float around in the blood. They need to be dissolved or bound to a protein to get around. Now, here's the different thing that happens with regards to steroids. Because they are lipid soluble, they can get into the cell very, very easily. So what steroids do, and we'll make a little, there's a little steroid molecule. It actually can go right into the cell and make its way to the nucleus, where it's going to cause some more transcription and translation to make more protein, to make more muscle, or whatever it's doing. That's where the steroids are going to have their effect. So they actually can get in and make its way into the nucleus and do all that stuff there. So they can either bind inside, or they can also bind to a surface receptor as well. But the majority of them are going to go right into the cell and go right into that nucleus. So those are the big things when it comes to steroids, how they're packaged and made versus amines and peptides. Okay, so this is a good review as far as the different types of hormones. Now, let's talk about hormone concentration. We need enough of the hormone to have an effect. Okay? Type 1 diabetics don't make any insulin, so they're not going to have any effect because they don't have the hormone. There's not enough concentration to have its effect. So, depends on how many receptors are occupied on the target cells. And this depends on the free hormone concentration in the ECF. Why are we looking at free hormones? If they're free from a protein, they're active. If they're bound to a protein, they're not working anymore. They're inactive because they're bound to the protein. But if there are free hormones floating around, they're going to have a concentration that you can measure. So the three things we had to look at to see what the concentration of this hormone in the blood is the rate of secretion. How often is it being released into the bloodstream? That'll tell you how much you dumped into the system. Now, let's worry about elimination. How much are we eliminating from the blood? If you dump in 100 units, we eliminate 75, we're only going to have 25 units left. Is that enough concentration? Depends on the hormone. And then also the last thing is how much of it is bound to a protein. If you dump in 100 units and 50 of it get automatically swept up by a protein, you're only going to have 50 units left. And then you excrete 25 of that, now you're down to 25 units left in the blood. So when you talk about the concentration of the hormones, we're looking at how much is secreted into the blood, how much is eliminated from the blood, and then finally, how much are bound to proteins. Here's our feedback control mechanism, going right back to day one of physio. Most are negative. We do have a couple that we will learn in this section, not today, but in the reproductive, that are positive feedbacks. We already learned one positive feedback loop. Which one was the one we learned already that's positive? Blood clotting with platelets. That's a positive feedback loop. But again, most of them are going to be negative. That provides control over the hormone. So you have your endocrine cell. They're going to release a hormone that's going to have an effect on a target cell. That target cell will then release a hormone in response to that. And usually the hormone itself will turn off the endocrine cell. And when we go through the different hormones, we're going to pull this back out and you'll see the different pathways, and we'll talk about the negative feedbacks and where they shut things off. We also have hierarchical control when it comes to the hypothalamus and the pituitary gland. Negative feedback can occur at any level of the primary gland, anterior pituitary, or the hypothalamus. So whenever you talk about a primary disorder of a hormone, let's say you have primary hypothyroidism. So you have very, very low thyroid hormone in your blood floating around. If it's primary hypothyroidism, the problem is in the primary gland, which is the thyroid gland. That is a primary issue. If the pituitary gland is not secreting the hormone that needs to be stimulating the thyroid gland, which is TSH, if the pituitary gland does not secrete TSH, the thyroid will not be told what to do. You will not make any thyroid hormone. That is a secondary problem because the issue is in the pituitary gland, not the thyroid. Finally, you can have tertiary, and that is with the hypothalamus. The hypothalamus releases all of the releasing hormones. The pituitary gland releases more of the stimulatory hormones. So the hypothalamus is the releasing hormone. The pituitary gland is more of the stimulating hormones. If your hypothalamus is damaged and you can't secrete any of the thyrotropin releasing hormone, TRH, that will never tell the anterior pituitary gland to release TSH, which is thyroid stimulating hormone, which will never get to the thyroid gland. So in that case, that's considered tertiary hypothyroidism because the hypothalamus is not working. Makes sense as far as the hierarchy and how you figure out where the problem is. All this comes out with labs. You got to figure out labs are the way to know, is this a primary problem, secondary, or a tertiary? You got to know what the labs are. Few cases, again, have positive feedback. We'll learn about this next unit when we talk about reproductive, FSH and LH. And we'll deal with that more next chapter. So we also have to know about, with regards to specific hormones, when are they being released in the body? Some have a circadian rhythm, a day and night pattern of secretion. This is your cortisol. Has a circadian rhythm. It's usually going to be released a lot in the morning when you wake up, and it's usually pretty low at night before you go to bed. If you have a child or you're going to be having a child and you breastfeed, if you pump into a bottle or bag and you save it for later, put the time that you put the breast milk in the bag. When did you pump? If you pumped in the morning, you're going to have a lot of cortisol in the breast milk. If you give that baby that cortisol-laden breast milk at night, They will not go to sleep because they're getting a huge dose of cortisol, which is going to wake them up. Time the bag. The cortisol will have an effect. If you pump in the morning, give that in the morning. If you pump at night, give it at night because it's going to make the baby go nuts. If you ever do intermittent fasting and you've gone for like a 48-hour fast, sometimes you get like wired at night, and that's because of cortisol. Cortisol is a hormone that comes out when you are hypoglycemic. If you haven't eaten for 24 hours, you're going to be hypoglycemic. So at night, you may get a sudden rush of energy because this cortisol is coming out to raise your blood glucose. So if you ever do intermittent fasting, you get wired at night, that's why. So when should you, if you had to measure a cortisol level on someone, knowing that we know that the highest peak is in the morning, when should you do your cortisol checks? In the morning. For all cortisol, always check in the morning because you have to understand the the circadian rhythm of the cortisol. Pulsatile pattern. This is like insulin. It only comes out after you eat. So if you eat something, then you're going to get a pulse of insulin because you ate something, sugar's in the bloodstream, you got to get rid of it so it comes out. So for instance, because we know it's a pulsatile pattern for insulin, we can do what's called a glucose tolerance test. I'm going to give you a known amount of glucose, a sugary drink. I want you to drink it. It's like usually like 75 grams of sugar in that bottle. Drink the whole thing. Every hour after that, I'm going to check your blood sugar. And I better see after about an hour, 2 hours, that number better starts going down because insulin is now out from a pulsatile secretion to handle all the glucose that came out. So again, just be very careful when you do your blood draws, knowing what you know about the pulsatile release or the circadian rhythm of these hormones. Night pattern, growth hormone only comes out at night during deep sleep. If you want to get muscles, you better sleep because if you don't, you're not going to make any growth hormone, nothing's going to happen. Okay. So about elimination of the hormone. They all have a half-life. Time it takes to reduce the concentration of a hormone in half. We also talk about clearance here. Okay, that was a question on your exam today, right? Clearance was the answer. The amount of a solute rendered free of the plasma in 1 minute is clearance. We have metabolic clearance for hormones as well. How do they get removed? Either metabolism or binding to the tissues, and either we can get rid of it in the liver or in the kidneys. So that's how we can get rid of hormones out of the bloodstream, metabolize it, bind it to a protein, get rid of it in the bile, or filter it out in the kidneys. Only free hormone molecules will diffuse out of the capillaries and bind to the receptors. They have to be free. If they're bound to a protein, it reduces the concentration. If it's bound, it's inactive. Okay. Water-soluble hormones, your peptides and catecholamines, are not protein-bound. Because they're not bound to a protein, fast onset of action. Yes?
Are we going to get into how they unbind when they're carried, or do we just need to know?
Just know they'll break off on their own. So, for example, patient has liver failure, they will become hypoalbuminemic. Where is the protein deficiency, in the blood or the urine? The blood. That was a question today. It said hypo or hyperalbuminemia. That was not the right answer because that's in the blood. If it was hyperalbuminuria, then that is the answer because that means you have protein in the urine. But the answer was emia, so it's blood. So for example, if you do lose your binding proteins because your liver is not making the proteins anymore, for example, half of calcium is bound to a protein. If you don't have the protein anymore, you're going to have more free calcium floating around because it's not bound to a protein. So it's going to up your existing levels of calcium, and your calcium levels go up. Again, as an example, start thinking of these things globally. If they have liver failure, clotting proteins go down, binding proteins go down. Start keeping those things in the back of your mind, what they're used for. Hormone receptor intracellular signaling. The response to a hormone is only seen if that cell has the specific receptor for that hormone. Muscle cells have insulin receptors. Other cells don't have insulin receptors, so insulin will not have an effect on those non-receptor cells, but it will have effect on the cells that do have the receptor for insulin. So the response to a hormone is affected by the number of available receptors, the number of them. So the sensitivity to a hormone is related to the number of receptors that are found. If you ever hear the word upregulate, that means we're going to increase the number of receptors. And downregulate is we're going to decrease the number of receptors. If we're going to upregulate something, we're making more receptors, therefore we will become more sensitive to the hormone. If we downregulate, we're going to decrease the sensitivity to that hormone. Insulin, if you lose your insulin receptors, you're not going to be receptive or sensitive to insulin. That's one example. And the receptor is going to result in two things. Generation of an intracellular second messenger. We had mentioned before that cyclic, the CAMP or CGMP, those are secondary messengers. We're going to talk about those today. They amplify the hormone. That's what secondary messengers do. They amplify the effect of that hormone. Or in the cases of steroids and thyroid on some occasions, they're going to get right into that nucleus and cause some more gene transcription and translation to make more proteins to do whatever it's got to do. So that's how we can increase the sensitivity to these hormones. Secondary messengers amplify the signal of that hormone. For peptides and catecholamines, they have secondary messengers. They're all going to activate G proteins inside the cell. Once that happens, there are three things that could happen afterwards as far as secondary messengers, and we'll go through those individually. First one, cyclic AMP. If you look on the side here, there's our hormone. It binds to a surface receptor. And when it binds to that receptor, it activates the G protein complex. You don't need to know the alpha, beta, and gamma parts of it. Just know there is a G protein coupled to the receptor. And when a hormone binds to that receptor, it activates the G protein. And in this case, it is bound to adenylyl cyclase, okay, formed by ATP by adenylyl cyclase. Can be stimulatory or inhibitory. So just because we're binding to a receptor doesn't always mean it's going to be stimulatory. It could be inhibitory as well. When we activate adenylyl cyclase, we're going to then activate our cyclic AMP, which then is going to activate protein kinase A. So just like we've done for all the other things, walk your way through it. The hormone is going to bind to the receptor. The receptor will activate the G protein, which will then activate the adenylyl cyclase, activating cyclic AMP, which then is going to turn on protein kinase A. This is all happening inside the cell. We've amplified that signal from that one hormone that bound to one receptor, we've amplified it inside. Cyclic AMP is broken down by phosphodiesterase enzymes. Okay? So you have to know that. Cyclic AMP, phosphodiesterase. Just like acetylcholine, acetylcholinesterase metabolizes acetylcholine. Phosphodiesterase metabolizes cyclic AMP. Clinical correlation with cyclic AMP. Phosphodiesterase type 3, also known as PD or PDE. Oh, this one's 3. We'll get to the 5 in a second. And it breaks down cyclic AMP. So, if I give you phosphodiesterase 3, and if I tell you that cyclic AMP is in cardiac muscle, and I give you phosphodiesterase 3, which is going to break it down, is the cyclic AMP going to have a bigger effect or a reduced effect? Reduced effect. If it has a reduced effect, we're not going to have that same type of squeeze. So as an example, we have a drug called milrinone, which inhibits phosphodiesterase 3. So what's going to stick around longer? Cyclic AMP to have more of an effect, and the end result is contractility in cardiac muscle and vasodilation. You don't have to know all that about milrinone. It just as an example showing you that we can alter these enzymes that break down these things to have that secondary messenger system work longer and have more of an effect. So that's cyclic AMP. Adenylyl cyclase activates cyclic AMP, which then activates protein kinase A. Here are the other two, DAG and IP3. And this one, instead of being adenylyl cyclase, we have PLC, phospholipase C. Still have hormone binding to a receptor, activating the G protein. The difference here is it's going to activate PLC instead of AC. If you have calcium present, the DAG secondary messenger will activate protein kinase C. This is one path it could take. In the presence of calcium, okay, DAG will synthesize or cause PKC, protein kinase C, to be activated, and you'll have an effect inside. IP3, if we talk about an IP3 as a secondary messenger, that is going to release calcium. So DAG as a secondary messenger system uses PLC and PKC. If it is IP3, it's going to release calcium. I will tell you in a question which one it is. As we go through the specific hormones, I'll tell you, okay, this one binds to IP3, this one's a DAG, this one's a cyclic AMP. Yes?
So PLC is the secondary messenger?
The PLC kind of activates the whole thing.
Okay.
We're worrying about the DAG and the IP3, that middle row.
Okay.
There are other secondary messengers. These are not dependent on G proteins. First one, tyrosine kinase. This is what binds insulin. It is not a secondary messenger. It just causes a cascade of reactions. The other secondary messenger is cyclic GMP. Okay. Examples include atrial natriuretic peptide. Cyclic GMP, we talked about cyclic AMP was broken down by PDE3. Cyclic GMP is broken down by PDE5, phosphodiesterase type 5. Cyclic AMP is 3, GMP is 5. So, clinical correlation. What drug is that? Viagra. It doesn't say Viagra. What does it say? Well, sildenafil is the generic for Viagra. Viagra is the brand name. This one's called Revatio or Revatio. What this one is, it's sildenafil, it's Viagra. It's a PDE5 inhibitor. So if we're going to inhibit PDE5, cyclic GMP starts to build up in the cell. When that happens, it causes vasodilatory effects in the pulmonary and the penile vascular bed. This drug, Viagra, was originally made for hypertension because it's going to cause vasodilation. It didn't work very well for hypertension, but guess what? The side effect that the men were not complaining of, I guess you could say, but the men were getting. So they pivoted the drug and made it as a erectile dysfunction med. However, it does do a good job with the pulmonary vasculature and dilating those as well. So patients who have pulmonary hypertension, they're not systemic hypertension, but within the pulmonary vasculature, they have hypertension there. We give them Revatio, which helps those vessels open up, reducing the pressure. But obviously, we also give it for erectile dysfunction. So that's where PDE5s come into play. So remember, 3s are for cyclic AMP, 5s are GMP. The last one for secondary messenger are these eicosanoids. Okay, these are secondary messengers derived from arachidonic acid. Okay, here is your arachidonic acid. Okay, phospholipase A activates arachidonic acid. Then arachidonic acid can go through 2 different pathways, a COX pathway or a LOX pathway. COX pathway starts with prostaglandins and thromboxanes. The LOX pathway deals with leukotrienes. NSAIDs block the COX pathway. Prostaglandins and thromboxanes cause pain. The prostaglandins give you a sensation of pain. If you block the creation of the prostaglandins, what will you not feel anymore? Pain. That's where these Advil, Motrin come into play. They just block the generation of prostaglandins and thromboxanes, and the inflammation and the pain kind of go away. Okay, these differ from other secondary messengers because they are hormones themselves. And secondary messengers depend on the enzymes that they express. So these are the eicosanoids from arachidonic acid. Here's our steroid and thyroid hormone signaling. Remember, they don't really have those surface receptors. Steroids sometimes do. For the most part, steroids and thyroids, you see here, steroid, they go right in. When they're in the cell, they bind to a steroid receptor. We're still in the cell. And then this whole thing goes into the nucleus for transcription and translation to make more protein, whatever it is that needs to be done with those steroids or the thyroid. Okay, that's pretty much all steroids and thyroids do. They get into the cell, get into the nucleus, embed themselves in the DNA, and they start zipping out more proteins that they need. Okay, that's that one. Okay, where are we at? Okay, we can start this. Hypothalamus and pituitary. Pituitary is the master gland because it controls a lot of secretions for a lot of different things. The secretion of pituitary hormones is controlled by release factors from the hypothalamus. So this is called the hypothalamic pituitary axis. There's negative feedback from primary target glands, and they can either modulate release from the hypothalamus or the pituitary. They'll pick one. Anterior pituitary has 6 major peptide hormones. Growth hormone, TSH, adrenocorticotropic hormone, ACTH, follicle stimulating hormone, luteinizing hormone, those are all reproductive stuff. We'll deal with that next chapter. And prolactin. Prolactin is the only anterior pituitary hormone not secreted in response to a stimulatory hypothalamic hormone. That's the only one, prolactin. Everything else has a releasing hormone from the hypothalamus telling the pituitary what to do. Prolactin doesn't. It's under negative control by dopamine. So they didn't know it was dopamine when they were figuring this stuff out many, many, many years ago. They knew there had to be something inhibiting prolactin release. They didn't know what it was. They just called it prolactin inhibiting factor, PIF. Later on, they found out, oh, this is just dopamine. So it's dopamine. So you may see PIF or dopamine. It's the same thing. They just didn't know, depending on what book you're looking at. That's what they say. So for people who have prolactin tumors, they're tumors that keep secreting lots and lots of prolactin, what drug do you think you want to give them to stop the release of prolactin? Dopamine. We give them a drug called bromocriptine, which is a dopamine agonist, to reduce the amount of prolactin being released. Okay? And we talked about that already. So hyperprolactinemia, men may get milky discharge from the nipples because all this prolactin is being released. When we get to like how we develop our organs, all fetuses when they are first made are all females. That's why guys have nipples. So there is breast tissue there. It's not developed at all because we don't have the hormones to develop it, but they are there. And when you have high levels of prolactin, it can start production of milk. Prolactin makes the milk. Oxytocin lets it down. So we'll get to all that later. Okay, on this one, we're just going to do the bottom part, and then we'll take a break. So the first level that we're going to talk about is the hypothalamic hormones. Okay, first one we'll talk about CRH, corticotropin releasing hormone. CRH. It's a releasing hormone, and it has to come from the hypothalamus. Corticotropin. Cortico. What is that referring to? Cortex. Which specifically are we talking about? The adrenal cortex. Corticotropin releasing hormone. So it does that. The next unit down is going to be what pituitary cell that are being activated. When CRH is released from the hypothalamus, it's going to go to the anterior pituitary and it's going to bind to the corticotrophs. Okay, troph. What does trophy mean? To grow. Hypertrophy. Okay, grow. Corticotrophs are the cells that make the next hormone, which is going to be ACTH. So the next section down, the third row, is the pituitary hormone. And the last bit, what is the target organ or target tissue? In this case, with CRH, is the adrenal cortex. So hypothalamus releases CRH, binds to the corticotroph cells in the anterior pituitary to release ACTH, which is then going to travel in the bloodstream to the adrenal cortex to have an effect there. And we'll get to that when we get to adrenals later. The next one This is growth hormone releasing hormone. Growth hormone releasing hormone. Remember, all the releasing ones have to go to or leave the hypothalamus. So if it's a releasing hormone, it comes from the hypothalamus. GHRH is going to go to the anterior pituitary, and it's going to target the somatotrophs. My pen is lagging, so. Soma, what does that mean? Body. That's where the body growth cells are. Okay, somatotrophs are going to release growth hormone, and that's going to go to our musculoskeletal system. Like our muscles grow, our bones grow, so we can get height. Now, there is a hormone that's going to stop the release of growth hormone. At that level, somatostatin. Where have we heard that one before? GI. What I tell you, remember about somatostatin? Stops everything. Okay, so somatostatin prevents growth hormone releasing hormone to release from the hypothalamus. So therefore, we will not have any growth hormone released at all. Okay, the next one. GN, a little n, RH. Gonadotropin releasing hormone. Don't confuse this with GHRH. This is GnRH. Gonadotropin releasing hormone from the hypothalamus. And they are going to stimulate the gonadotrophs. Okay, cells that make the gonads. These are going to release two hormones, FSH and LH. Follicle stimulating hormone and luteinizing hormone. Targets for here are the gonads. Testes and ovaries. And we'll deal with this a lot more next unit, next chapter, whatever. The next one, let me change the color again. This is your thyrotropin releasing hormone. Again, it's a releasing hormone. They only come from the hypothalamus. What cells do you think this is going to, based off of the nomenclature we've already gone through, what do you think these cells are called? Thyrotrophs. Yep. Okay, thyrotrophs. This is going to tell the anterior pituitary to release TSH, thyroid stimulating hormone. And this is then going to go to the thyroid. The last one is prolactin. Prolactin doesn't really have one per se. Remember, there's nothing really coming from the hypothalamus. But we do have lactotrophs. These lactotrophs are going to make prolactin. Bless you. Prolactin, when it gets released, it's going to have its effect on the mammary glands. Now, we did say, what is the thing that's going to inhibit prolactin release. Dopamine. So up here, we will put dopamine here, because we know dopamine is the one that shuts off the lactotrophs from making prolactin. Those are the hormones of the anterior pituitary. Yes?
So it's not coming from the hypothalamus. Where does it come from?
Anterior pituitary itself.
Oh, okay.
Okay, when we go through each section, we're going to pull out where the negative feedbacks are. So let's take a break, come back at 1:35, and we will continue on. Okay, we'll get started. So here on out, we're just going to go through the hormones. Now it's just hormones from here on out. With regards to the anterior pituitary, all the hormones in the HPA axis, or hypothalamus pituitary axis, are all pulsatile secretions superimposed on circadian rhythm of secretion. So what does that mean? We need pulsatile release. We don't want constant release of hormones. We become desensitized to them if we have constant bombardment of these hormones in high concentrations. We're going to down-regulate. And when you down-regulate, what does that mean? You decrease the number of receptors, so therefore that hormone won't have the same effect. Who here has taken like a Medrol dose pack, the steroids? What's special about it? What do they make you do? Taper off, right? You start off with like 6 tablets, then you go to 5, then 4, 3, 2, 1. They give you a big blister pack. Why is it important that you have to wean yourself off of the steroids, which is basically a form of cortisol that you're taking? If you kept those high doses all the time, you can, in a way, down-regulate the way that your body works with cortisol, so that when you take off the cortisol, you don't take it by mouth anymore, your body can't pick up the slack anymore, and you become hypocortisolic, I guess you can call it that way. Low cortisol because your body won't pick up and redo it again. You desensitize yourself to cortisol by taking it orally so much, it's not going to have the effect anymore. So by tapering off, you allow your own body's sensitivity to kind of kick up again. People who take steroids, like testosterone steroids, okay, make sure you know there's anabolic steroids like testosterone, DHA, those things. Then the other side of steroids, your aldosterone, cortisol. People who take steroids for muscle growth, if they take it all the time, what organ makes testosterone in your body for males? The testes. Well, you don't need them anymore because now you're taking all your testosterone exogenously through a needle. Your testes won't be sensitive anymore, and that's why they atrophy, they go away, and once you stop the steroids, some function may not come back anymore because you down-regulated it so much, desensitized yourself so much with this constant bombardment of that hormone has a negative effect. That's what they're saying here. That pulsatile allows for a gradual release of the hormone, so it stays at a constant level. Growth hormone is the first one we're going to talk about. Regulator of final body size. So what it does, growth hormone indirectly through stimulation of insulin-like growth factor, also known as somatomedin C. Growth hormone causes IGF-1 to be released. Insulin-like growth factor, that's what makes you big. That's why people who are, when they're pregnant, if they have gestational diabetes, they take insulin, the baby gets huge because you're giving it more insulin than it should have. Insulin-like growth factor, they kind of go together, baby gets big. Growth hormone causes acute metabolic effects that oppose the effect of insulin. What's insulin going to do? Decrease blood sugar. Growth hormone is the opposite. It's going to raise your blood sugar. Causes lipolysis in the adipose tissue. What does that do to your fat tissue? Breaks it up. So what happens to your fat mass? Decreases. That's what you want. You don't want a lot of fat mass. You want more lean mass. So growth hormone causes lipolysis in adipose tissue, but the consequence of that is going to dump all this glucose into the bloodstream. Reduced glucose uptake in the muscle. Where's the glucose going to stay now? In the blood, raising your blood sugar, again, antagonistic to insulin. And gluconeogenesis in the liver. What's gluconeogenesis? New glucoses, usually from amino acids or some other new substrate. So we're making more glucose in the liver to put into the bloodstream. So growth hormone, through these three effects, raises the blood sugar. And pulsatile secretion during those first 2 hours of deep sleep. Has to be deep sleep for you to get the growth hormone to be released. So you can see here, sleep, there's a big rise in growth hormone level. Exercise also causes growth hormone to be released. So exercise is good. So in acute stress, exercise or trauma, exercise really is a stress to the body. We do it for therapeutic purposes, but it's really a stress to the body. It's a good stress, but it is a stress. It does cause inflammation and a bunch of other things. One of the good side effects is growth hormone secretion. Is that important to have during exercise or trauma? You want more glucose in the blood. Short-term hypoglycemia stimulates growth hormone release via ghrelin. So starving causes intermittent fasting, causes growth hormone to come out. That's how you lose weight with intermittent fasting as well, because more growth hormone, more lipolysis, more fat mass is being melted away. Long-term starvation is a potent stimulus for growth hormone secretion. That's the intermittent fasting, the long-term starvation, not the short-term. But again, growth hormone comes out, puts more glucose into the bloodstream. That's the net effect at the very end. It's going to cause more glucose in the bloodstream. Here's our IGF-1. So this is what I'm talking about. Start drawing these things out. We have the hypothalamus telling the anterior pituitary to release growth hormone. This is your growth hormone releasing hormone. It's just not there, but that's what it is. Stimulates anterior pituitary to make growth hormone, which then is going to stimulate IGF-1. These dashed lines show the negative feedback. So IGF-1 has a negative feedback at the anterior pituitary and the hypothalamus. So when there's too much IGF-1 in the system, we don't want this much. We need to shut down growth hormone production. So IGF-1 will inhibit the anterior pituitary and the hypothalamus. Growth hormone only affects the anterior pituitary. Start getting these pathways down. So 90% of IGF-1 is bound to a protein. So he said when it's bound to a protein, it's inactive. But the fact that it's bound to a protein is that you have constant release of the IGF-1 over time. Growth hormone gets squirted out at once, but IGF-1 is going to linger around for a long time. Why? Because it's bound to all these proteins. So you get a slow release of IGF-1. It's a constant release of IGF-1 due to a pulsatile secretion of growth hormone. Okay? Posterior pituitary gland, ADH, oxytocin, ADH, they come from the hypothalamus. Don't worry about where they come from. Released Exocytosis triggered by an active potential. For posterior pituitary, remember these are neuroendocrine. Okay, so neurally mediated gets ADH going. And we're not going to review ADH because we did it already, so we can skip it. Now, oxytocin. Okay, it's a love hormone. Has a couple of purposes for oxytocin. One, uterine contraction. Okay, uterus is very sensitive to oxytocin late in pregnancy, causing powerful contractions. Okay, one of the drugs you can give to induce labor is called Pitocin, which is a form of oxytocin to stimulate uterine contractions to get this baby moving and get out. The uterine's got to contract to get that baby out. So we can speed up the process by giving a form of oxytocin, which is going to cause that. Cervical dilation is another positive feedback, so that cervical os keeps getting bigger and bigger to allow the baby to come through. Milk letdown and milk ejection. So there's a suckling stimulus, okay, that causes when the baby suckles on the mom, that from the nerve input, the sensation that she's getting tells the brain, hey, there's a suckling reflex. Let's get oxytocin going because there's a baby here who needs milk. And the oxytocin is needed for the squeezing of those ductors, the duct tubes to release the milk and let it go. Prolactin makes the milk. Oxytocin lets it move and gets it flowing. Okay, so there's two different hormones. Hearing a baby cry can also stimulate oxytocin release. Okay, if you ever watch The Office, there was an episode where after Jen or Pam gave birth, the guy starts crying in front of her to see what would happen, but that's where that comes from. So crying, a mother hear a baby cry will stimulate oxytocin release, milk letdown if she's breastfeeding. And also helps with maternal behavior as well. So oxytocin, induction of labor, but we also can use it for postpartum hemorrhage. Okay, so if you deliver the baby, there's a lot of bleeding going on. As soon as that baby's out, the uterus contracts a lot. It gets very small again. Sometimes the uterus doesn't want to squeeze tight after the baby's out. So we give another form of oxytocin again because we know it causes uterine contraction. It's going to, remember, what's the first step in hemostasis? There you go, vasoconstriction, right? Vasoconstriction. We are squeezing down on that uterus. We are constricting all those vessels to stop the bleeding. That's what this does. Oxytocin for a postpartum uterine hemorrhage. Any questions about oxytocin or growth hormone? Okay. Thyroid. The thyroid hormones are T4 and T3. Okay, they are big with our metabolic rate. Metabolic rate is how many calories are you burning just sitting here at rest. If you have a faster, higher metabolic rate, you're going to burn more calories just sitting here. If you have a lower metabolic rate, you're going to burn less calories. That's what that metabolic rate is. Has thyroid follicles, which contain thyroid colloid. What is colloid? Protein-rich, produced by endocrine cells surrounding it, called follicular cells. So the follicular cells can become cancerous. That's one of those cells that causes thyroid cancer. The major protein is thyroglobulin, and that is what binds the thyroid hormones so they can get around. It also secretes calcitonin from the parafollicular cells, which is not really part of the follicular unit with the thyroid, but the major thing it does with the calcitonin, it has to do with calcium metabolism. We'll get to that later on when we talk about calcium. But calcitonin will come back a little bit later. It's very, very weak though. Thyroid gland, the majority of it is going to be T4, T3. Thyroid cancers depends on what cells are being affected by it. Most common is papillary thyroid cancer. This we're going to skip. You don't need to know all that stuff about how we make thyroid. Now, here's the important thing. When we make thyroid hormone, there's two forms, T4 and T3. T3 is the more metabolically active hormone compared to T4. There are much more numbers of T4 than there are T3. What happens is T4 gets converted to T3 in the periphery. So it's a way to keep having constant thyroid hormone around by releasing the active and the inactive form. And over time, the inactive form becomes activated, so you have constant thyroid hormone going on. 75% of circulating T3 is coming from the deiodination of T4. So T3 means it has 3 iodines. T4 means it has 4 iodine. The thyroid is the only thing we need iodine for. How do we get iodine? It's in our salt. So next time you're in the supermarket, look at the salt aisle. It says iodized salt. So in US, we get our iodine from the salt that we get. What are the actions? We know because it's a thyroid, gene transcription and translation. It's going to get into the DNA. Only the free T4 and T3 can enter the cells. If it's bound to a protein, it can't get in. So it's got to come off that protein. Primary effects of thyroid hormone: increase your basal metabolic rate. So you're going to burn more calories at rest. So people who have hyperthyroidism are going to be thin, maybe a little irritable, on edge, because the metabolic rate is really ramped up and high. People who have hypothyroidism, sluggish metabolism, they're going to be overweight, some other issues going on as well. But again, think about, we know what the effect of thyroid hormone is. If we have too much of it or too little, what's going on? Induces gluconeogenesis. What's that going to do to our sugar? Bring it up. Raise our sugar levels. If we are having this metabolic rate, we need something for all those muscles to eat. And that's where the glucose comes in. And coordinates normal growth and development. Babies who don't have a functioning thyroid will look different compared to other babies. It's called cretinism. I'll sit in now, my Apple Pencil doesn't want to work. Cretinism, it's just they have a weird facial features. You give them some thyroid and they go back to normal. So thyroid is very important for growth and development. If you don't have a very well-functioning thyroid, you're going to have problems. So increasing BMR, your basal metabolic rate, stimulation of futile cycles. Okay, so what happens is we get catabolism and anabolism. So these futile cycles, we're going to go breaking down things and then we're going to build them back up again. When this happens, you get body heat. So people who have hyperthyroidism are going to feel hot and sweaty all the time because they're generating all this heat from these futile cycles. So they're going to be sweaty, they're going to be hot. If you have hypothyroidism, you're going to be cold because you're not generating this extra heat, and you have a slower metabolic rate. So you're going to have cold intolerance. You get cold easier with hypothyroidism. Brown adipose tissue. Normally we have all white adipose tissue. There is brown fat, mainly found in babies. People who do like the ice fishing and their hands are always being submerged in ice water all the time, they will get brown fat distributed on their hands. Brown fat is insulating, it's generates heat. So that's why people who are always putting their hands in cold water like the fishermen all the time, they're going to get brown fat around their hands to provide insulation and warmth for their hands, always going to the cold. Brown fat is very, very highly metabolic active, so the more brown fat you have, the more weight you can lose easier, because brown fat will just churn through all that stuff real fast. Also has increased expression of beta-adrenergic receptors. What type of system are we talking about here with betas? Sympathetic. What do you think is going to happen to your heart rate? Increased. So people who have hyperthyroid have a very fast heart rate because we're activating our beta receptors. Heart rate kicks in. If you have hypothyroidism, you got bradycardia. Nothing stimulating the beta receptors, so your heart rate relaxes and goes back down. And we talked about that already. This we've already talked about already. So this is important right here. Yes, it's going to increase their glucose in the blood. However, all things being equal, as long as their pancreas is still working, they're going to make insulin. So they're not going to become hyperglycemic per se, because they still have the insulin there to handle that excess glucose. As long as insulin's there, they won't become hyperglycemic, but obviously the thyroid hormone is going to help that. And your normal growth and development, there's your cretinism. Okay, here's your picture again. T3 and T4 have negative feedback at the anterior pituitary and the hypothalamus. TSH has a trophic effect on the thyroid gland. What does that mean it's going to do? Make it grow. So people who have hypothyroidism, let's talk about feedbacks now. If I don't have any free T4 or T3, my thyroid is not working, I'm not making anything, is there going to be any negative feedback exerted on the anterior pituitary or the hypothalamus? No. So what is going to be constantly high trying to get the thyroid gland to pump out some hormones? TSH. That is why people who have hypothyroidism have low T3, T4, but the TSH is going to be really high because it's like that meme where the, poking with a stick, like, come on, do something. That's what the TSH is doing. It's like telling the thyroid, come on, do something. I'm not getting any thyroid hormones. I need more. So when you have a lot of TSH bombarding that thyroid gland, it can get a little bit bigger. And that PAs, and you can start doing your thyroid palpation. If it's enlarged, you'll feel it. If it's not, then you won't. So that's the negative feedback. Make sure you know that one. Any question about thyroid? The stuff is very straightforward. It's just a lot, so just keep it straight. Know, okay, if I'm dealing with thyroid, these are the only things I'm worried about. If I'm dealing with the adrenal, which we're getting to now, these are the only things we're going to deal with here. Okay, within the adrenal cortex, there are 3 distinct zones, and there are 3 distinct zones because they have certain properties in each of those zones that allow you to make certain hormones. The zona glomerulosa makes aldosterone. Why? It has an enzyme, that's aldosterone. Aldosterone synthase is located only in the zona glomerulosa, so it's going to make aldosterone in that zone. The zona fasciculata is going to make cortisol, and the zona reticularis makes the androgens, and obviously the medulla is our catecholamines. So memorize this part. Know glomerulosa is aldosterone, fasciculata is cortisol, and the reticularis is the androgens. Structure of these adrenal glands. Okay, it's distinct from the cortex and it has chromaffin cells. Richly innervated pre-ganglionic sympathetic neurons. ACH as the neurotransmitter because it's in the ganglion. We're not at the target yet. Sympathetic still uses ACH in the ganglion. Chromaffin cells secrete a little bit of epinephrine plus a small amount of norepinephrine in response to stimulation. So these medulla has the chromaffin cells which make the epi and norepi. High concentrations of cortisol stimulate epinephrine synthesis, and this helps with the stress response. When you are stressed, cortisol goes up. When cortisol goes up, we need a little bit more epinephrine to help with our stress responses. So cortisol helps synthesize epinephrine later on. And I'll show you how that works. So this is the direction that blood's going to go when it gets into the adrenal cortex. At the very, very bottom is the medulla. Then you have your glomerulosa, fasciculata, and reticularis. So as the products come down, depending on what's in the blood, it may interact with the glomerulosa, it may interact with the fasciculata, reticularis, and whatnot. But what we were saying before is, what zone makes cortisol? The fasciculata. So this zone right here, the fasciculata, is going to make cortisol. If it's making a lot of cortisol, all that cortisol gets dumped into that bloodstream. And this cortisol is going to work its way down, and eventually it's going to hit the adrenal medulla. This cortisol that's coming through these arteries, the blood supply, the portal supply, when it gets to that medulla, that cortisol there will also help give a little boost to epinephrine synthesis, which only occurs in the medulla, to help with stress responses. Cortisol is a stress hormone. Okay, I'm sure all of you have had high cortisol at some point already this summer. The constant release of cortisol over time in a stress response for long term is not good. You start getting sick easier, skin won't heal as well. So usually in the fall, people start getting sick because the cortisol level just runs rampant for a while. So anyway, that's the structure of the cortex going into the medulla. It's one blood supply going down. As it goes through different zones, that's where you can make the different hormones depending on what substrates are there. Mineralocorticoids is your aldosterone. We know what aldosterone does. Glucocorticoids. It's got gluco in it. This is your cortisol. Has glucose. So remember, glucose and cortisol go together, but increased blood glucose concentration. And our sex steroids, androgen, estrogen, and progestins. What don't you see there? Testosterone. Why? It's only produced in the testes. So all these androgens, DHEA, are precursors, and they stimulate the testes to make testosterone. So you don't see it here. They're all very weak androgens. Yes?
So then, I don't know if I've ever heard this, but don't women sometimes have testosterone or no?
So if there's certain conditions where it's not Addison's disease, it's a form of Addison's. But basically, there are certain enzymes, which we'll get to, which are required to make cortisol and aldosterone. If you don't have those enzymes, you can't make any cortisol or aldosterone. So what happens is all the products that go into making cortisol, aldosterone, and sex steroids, because you can't make cortisol and you can't make aldosterone, you have all these products just sitting there. They all get converted into androgens. And in women, they can be strong enough to cause hirsutism, growth, facial hair growth, and stuff like that. So that's where your question kind of comes into play with that. And again, only in the adrenal gland, and they produce weak androgens. Making steroids starts with cholesterol, mainly from the LDL. The rate limiting step in this entire cascade is the conversion of cholesterol to pregnenolone. That is the rate limiting step when it comes to steroid synthesis. You can have all the cholesterol in the world, but if you can't convert it into pregnenolone, it's not going to matter. So that is the rate limiting step, yes.
When I used to see patients that when they have like Addison's disease, we'd give them like cortisol.
You have to, because they can't make it on their own.
Right. So when they were sick, like they would take more. So does cortisol like help you?
Yep. So when it's a stress hormone. Anytime you're stressed, cortisol needs to go up to handle the effects. And we'll get to that as we get to it. If you have what's called Addison's disease where you don't make any cortisol, you still need cortisol, so you have to take it every day. But we tell them, if you're sick, you're going for a big exam on Monday, whatever, take an extra dose of cortisol to handle that stress response. It's like insulin. If you have a big meal of carbs, your insulin's going to skyrocket to handle all those carbs. If you don't make insulin, you still have to handle it, so you have to take insulin exogenously to handle whatever you took. Cortisol is the same thing. You need it for the stress response. The identity of the final hormone depends on what other enzymes are also expressed. So I mentioned before, aldosterone has the aldosterone synthase enzyme that allows that area to make aldosterone. Cortisol, they have this enzyme, 17-alpha hydroxylase, that is needed to make the cortisol. If you don't have that enzyme, you can't make cortisol. Weak androgens, they don't make any, there's no really enzymes to produce testosterone and estrogen. That's why they go to the testes or the ovaries, because they have the enzymes there. Progesterone is produced, but is used in synthesis of cortisol and aldosterone rather than being secreted. We're going to talk about progesterone when it comes to pregnancy, maybe Thursday, but definitely next week. Okay. So here is cholesterol to pregnenolone. This is that rate limiting step. Okay, that conversion of cholesterol to pregnenolone. Now, don't worry about all the other words and all there. All you have to know for right now is cholesterol to pregnenolone is the rate limiting step. Once we have pregnenolone, it can be converted to progesterone, and with the effect of this 21-alpha hydroxylase, now we can get to cortisol and our aldosterone. So 21-alpha hydroxylase is needed for the entire, to even get to cortisol and aldosterone. The 17-alpha hydroxylase is needed to make cortisol itself. And here's your aldosterone synthase. 17-alpha hydroxylase is needed to make cortisol. Aldosterone synthase is needed to make aldosterone. But the 21-alpha hydroxylase is the door to both of these hormones. If you don't have 21-alpha hydroxylase, that won't work, this won't work. All that pregnenolone is then going to go wind up as weak androgens when you have that deficiency in the 21-alpha hydroxylase. As long as you have 21-alpha hydroxylase, this whole thing will just keep working as long as you have that enzyme there. If you don't, then you run into problems. So 21 and 17 are the enzymes that allow you to make cortisol and aldosterone. 17 is the real big one that makes you make cortisol. And if you don't have it, then all that pregnenolone gets made into weak androgens. So what does cortisol do? Activated receptors for cortisol enter the nucleus and other gene expression. Less than 5 is bound, it's free, less than 5% is free. 90% is bound to transcortin, and 5 is bound to albumin. So albumin's here as well, but transcortin is the protein that transmits cortisol everywhere. So cortisol is secreted in response to virtually all forms of stress. So even in minor illnesses, not increasing your cortisol can be fatal. So much so that people who do have Addison's disease wear a bracelet saying that they have Addison's disease. So if they go into the hospital and they have altered mental status, the ER people can see, oh, they have Addison's disease. Let me just give them some cortisol and let's see what happens. So that's usually why they do that. So what does cortisol do? Mobilizes glucose, amino acids, fatty acids. Okay, raising your blood glucose. The other part, resists inflammation. Okay, that's why you give steroids for swelling. You know, if you ever get stung by a bee, whatever, and you swell up really bad, they can give you some steroids for that to help reduce the inflammation. Or you give non-steroidal anti-inflammatory drugs, the NSAIDs. Non-steroidal, but they still have anti-inflammatory properties. So glucocorticoids increase blood glucose, make new glucose, get amino acids from muscle cells to make more glucose, reduce cell metabolism of glucose to keep glucose in the blood, and reduces your sensitivity to insulin so the glucose stays in the blood. This is just telling you kind of what she was asking before about people who don't make any cortisol. We have drugs that we can give that have different activities. So hydrocortisone has both glucocorticoid and mineralocorticoid activity. Does both. Look at prednisone. Prednisone is pretty much all cortisol. Very, very little aldosterone activity. Then you have this last one here, fludrocortisone. Very, very, very high mineralocorticoid activity. If I told you that fludrocortisone has the same effect as aldosterone, what do you think me giving you fludrocortisone is going to do to you? Increase what? Which will do what? Water. Bring water in. What's the main effect of aldosterone? Raising your blood volume, right? To do what? Raise your pressure. Fludrocortisone we give as a volume expander. When people come in, they're severely dehydrated, they're not making any aldosterone, we can give them fludrocortisone. It's a volume expander. It acts like aldosterone. It's going to bring a ton of water back into the blood, increasing your blood volume. Yes?
Is that why you gain weight when you're on a steroid sometimes?
Yep. Also, it has to do with the glucose too. Okay. So here is the feedback for cortisol. You got to memorize this one too. Higher CNS functions, okay? Stress, circadian rhythm. We know that has an effect on cortisol release. Circadian rhythm and stress are the stimulations for cortisol. So we get to the hypothalamus, which is going to release corticotropin releasing hormone. Goes to the anterior pituitary. What cells is it going to attach to? The CRH in the anterior pituitary. What type of cell? Corticotrophs. Releases ACTH, which is then going to go to the adrenal gland to make cortisol. Now, cortisol itself has a negative feedback, anterior pituitary and the hypothalamus. However, in this case, ACTH will also have a negative feedback on the hypothalamus. We don't want cortisol being released unopposed, so we have two ways to control it. Cortisol feedback itself and the ACTH can also feedback on the hypothalamus saying, stop releasing CRH, we got enough. So though we have two feedbacks to control cortisol release. Secretion, again, highest levels are in the morning. During stress, it goes up as well. And then at night, when we start going to sleep, cortisol starts to drop off, allowing you to go to sleep. And again, that's why, like jet lag, going to different places, your cortisol is still going to release at 8:30 in the morning wherever you came from. And if you're in California, at 5:30 in the morning, there goes your cortisol. So it depends on where you are. So synthesis and actions of ACTH. This molecule right here, POMC, pro-opiomelanocortin, POMC. You don't have to know anything else about this. The only thing you got to know is this. POMC is the precursor. It is going to dissociate. It's going to make ACTH and MSH, melanocyte stimulating hormone. So when you need a lot of cortisol, or people have hypercortisolism, now they have too much cortisol, like Cushing's syndrome, they will produce a lot of ACTH, but they're also going to make MSH as well. I'm sorry, this is Addison's. Addison's has low cortisol, so ACTH has to go up, right? We're not making any cortisol. If we're not making any cortisol, there's no negative feedback on the pituitary hypothalamus to stop making CRH ACTH. So we need a lot of ACTH being made. All this ACTH is being made also produces MSH. So the people who have Addison's disease have hyperpigmentation in the gums. It can happen there. The flexures of the hand, all the creases in the hand will become very dark. That's what hyperpigmentation is, again, due to the overproduction of ACTH when you have low cortisol. Primary action of ACTH, again, cortisol release in the adrenal cortex. Aldosterone secretion is controlled by angiotensin II and very weakly by ACTH. So ACTH is mainly just cortisol because the aldosterone release comes from renin and that whole cascade. So aldosterone, maintenance of normal extracellular fluid volume through conservation of our sodium, is also going to dump potassium into the tubule. It's going to secrete more potassium. So in the total absence of aldosterone, we have no aldosterone. Severe sodium depletion. Why are you depleted of sodium in the blood? Where's it going? Into the urine. And you get potassium retention. So you have to give some sort of aldosterone to these patients or the potassium is going to go crazy. So the control of secretion is the renin-angiotensin system. Renin, juxtaglomerular cells, in response to our low effective circulating volume, which we just went over, was on your exam today. 3 mechanisms that cause renin to be released. Reduced distension of the afferent arteriole. If there's less blood coming into the area, less dilation of the arteriole, so it's going to get smaller. Tubuloglomerular feedback, signaling due to low GFR or low renal tubular flow. And the last one is renal sympathetic nerves due to baroreceptor reflexes due to decreased blood pressure. It all has to do with volume. You have a low volume of blood, we need to bump it up. We need aldosterone to do that. So renin gets released. The role of renin eventually is going to cause angiotensin II to go up and aldosterone. So renin, first thing it does, cleaves angiotensinogen. If it has ogen at the end, what does it mean? It's inactive, and the angiotensinogen is produced by the liver. And renin, all it does is convert angiotensin 1 or angiotensinogen to angiotensin 1. That's the first step. The next step, angiotensin 1 is cleaved by our ACE, angiotensin converting enzyme, and that converts it to angiotensin 2. So let's put this. I can't even write anymore. Anyway, angiotensin 1 to angiotensin 2 is by ACE. This happens mainly in the lungs. Then that angiotensin 2 binds to the angiotensin 1 receptor in the zona glomerulosa. And that stimulates the aldosterone secretion. Why in the glomerulosa? What's there? The enzyme to make aldosterone. Very easy to remember. Aldosterone synthase. That's all it is. That's where the enzyme is. So when the angiotensin 2 goes to the zona glomerulosa, we get aldosterone release. That is the renin cascade, the renin-angiotensin-aldosterone cascade. So ACE inhibitors block angiotensin 1 to angiotensin 2. There's another type of drug called ARBs. And these are aldosterone receptor blockers. I think it's aldosterone. I can't remember what the A stands for. I think it's aldosterone. ACEs and ARBs. So they both, ACEs block angiotensin 1 to 2. ARBs block the conversion of aldosterone. So you can't make any aldosterone. So this is kind of like the graph. Kidney makes renin, angiotensinogen produced by the liver. It cleaves it to make angiotensin 1. Angiotensin 1 in the lung under the effect of ACE, angiotensin converting enzyme, makes angiotensin 2, which then goes to the zona glomerulosa in the adrenal cortex, where the aldosterone synthase is, and it'll convert angiotensin 2 to aldosterone. And then the aldosterone comes out, and it goes right back to the kidneys. So it all starts at the kidneys, and it ends at the kidneys. The other way that aldosterone can come out is when we have very, very high amounts of potassium. What does aldosterone do to potassium? Excretes it in the urine, so it gets it out of the blood. So the main stimulus for aldosterone, the whole renin cascade, is going to be blood volume, that low effective circulating volume. Another way aldosterone will be secreted is when we have very, very high levels of potassium, because aldosterone will take that excess potassium, dump it into the urine, and get rid of it. We don't like high potassiums or even low potassium. So that's where aldosterone will come into play, also with high potassiums. Where are we at here? Okay, we're almost done with this section, then we'll stop for the break. Okay. You don't have to know all the things, just know dopamine is a precursor to norepinephrine and epinephrine. And the other thing I want you to remember is this part right there. So we had said during periods of stress, we have a lot of cortisol production, which is normal. But this extra cortisol will also help make epinephrine. And this is where it does it. Okay? So that's one of the big things with regards to catecholamines. What else is in here? This is just repeating everything else again. Just understand dopamine is a precursor. Here's tyrosine. Again, another precursor. It kind of goes through a bunch of different steps. You don't have to know all these steps. Dopamine, norepinephrine, epinephrine. Cortisol helps the epinephrine make bigger values as well. What are the actions of circulating catecholamines? Again, this goes right back to our sympathetic nervous system, the adrenergic. Alpha 1s are coupled to G proteins, and they increase intracellular calcium. Which secondary messenger did we learn about before does intracellular calcium? IP3. Alpha 2 receptors suppress cyclic AMP. What does cyclic AMP do? It's a dilator. Remember, go back to the Viagra. Okay, we give them a phosphodiesterase inhibitor to keep the cyclic AMP around more, to provide more of a dilatory effect. Alpha 2 suppress cyclic AMP. What's going to happen to the vessel? Constriction. This is how norepinephrine, when it binds to the alphas, it causes vasoconstriction by suppressing the cyclic AMP. And finally, we have our beta 1, 2, and 3, and they're going to increase cyclic AMP. Epinephrine has a very high affinity for beta 1, beta 2, more than norepinephrine, but they both have an affinity for alphas. Norepinephrine really loves the alphas as well. So they help coordinate a short-term response, increase cardiac output, bronchodilation, and raise our glucose in order to feed our muscles with energy. And here's just a review again, what happens when you start messing around with your alphas and your betas. So just kind of review this one. Big ones to know: in the heart, SA node, myocardium, bronchiolar smooth muscle, circular smooth muscle, sphincters, which you should already know, detrusor wall. We'll get to the rest later. What this is telling you is this: who here has asthma? And take a albuterol, which is a beta agonist. What is a beta agonist going to do to your bronchial smooth muscle? Dilate it, right? That's the whole purpose of giving albuterol, beta agonist, to increase bronchial smooth muscle. But what happens, it's going to activate the betas, but it's not selective. It's going to activate the lung betas, but it can also activate the heart betas. What happens if the heart beta receptors get activated? Your heart rate goes up. Some people, when they take albuterol, complain of tachycardia. Their heart rate ramps up because of the beta agonist properties. It affects the lungs and the heart beta receptors, so there's a crosstalk. So you ever hear something called a non-selective beta agonist or a receptor blocker? That means it's non-selective. It can be beta 1 and 2. A selective beta blocker will only go after certain beta receptors. The last thing here is how we break down. Should be a review from neurotransmitters, COMT and MAO. Just remember those two. The last thing I want you to know is that regardless of whatever, if you're starting with epi or you're starting with norepi, VMA is the end result, and that's found in the urine. Vanilla mandelic acid, VMA, is found in the urine from a breakdown. So people who have what's called a pheochromocytoma, which is a tumor in the adrenal medulla that causes spikes of epinephrine and norepinephrine to come out randomly. One of the things that we do to see if they have any adrenal medulla problems, we do a 24-hour urine collection. So they get to carry a jug home with them and put it in their fridge, and then when they gotta pee, they pee in the bottle. And for 24 hours, they bring it back to LabCorp request, and we measure how much VMA is in it. And if it's very, very high, we know they have a lot of epi, norepi going around. And that's how we can do lab tests to figure out if they have any adrenal medulla problems. So VMA is the end result of the metabolism of the epi and norepi. COMT and MAO are here. Doesn't matter the order, just know the end result is the vanilla mandelic acid. Let's take a break. Come back at 2:35. Okay, so just so you guys give an update, what's going to happen the rest of the week or the unit. Okay, we might be able to finish today for endo. On Thursday, we have reproduction. Next Monday, there's no class. It got moved to Thursday. So next Thursday, it's a 4-hour block. We won't be here all 4 hours. And then next Friday's class is canceled. Next Friday morning. PAs, you got intro to PA exam now, but there's no reason for the class. You won't need it. So next Friday, the 18th, there'll be no class on Friday. Next Friday. Not for me anyway. Okay, next Friday, the 18th, there's no physio. We'll be done by then. Okay, moving on to the endocrine pancreas. We discussed the exocrine pancreas in the GI system. Now we're going to deal with the endocrine side of the pancreas. And it deals with insulin and glucagon are the two counter-regulatory hormones that deal with glucose balance in the blood. So diabetes is a disorder of insulin secretion where you're not making any insulin, or tissue insulin insensitivity, meaning that your tissues are not sensitive to insulin anymore, which means what happened to the receptors? Down-regulated. They went away, less receptors, less of an effect. So our islets of Langerhans in the endocrine cell and the pancreas. We have alpha cells, and they secrete glucagon. The beta cells, insulin, proinsulin, and C-peptide, which we'll talk about in a little bit. The delta cells is somatostatin, which is what? Stop things. Somatostatin. Now, this next line is very important when it comes to realizing how insulin and glucagon work with each other. Blood flows from the center towards the periphery. So, in this case, these little black arrows here show the direction of blood flow. It starts in the middle and it works its way out. Now, look at all the beta cells. Obviously, there's a lot of them, and they're mainly in the middle. And we have those dark, the red ones are the alpha cells, and they're the glucagon. What does the insulin have to do to leave the islet? What cell does it have to go across? The alpha cells. That's important because when insulin is being released and it bathes over these alpha cells, it shuts them off so that you don't make any glucagon. Glucagon and insulin are opposites. Insulin is going to lower your sugar, glucagon is going to raise it. You don't want both of them going out at once. So when insulin is being released, it bathes over the glucagon cells and it shuts them off. So insulin will shut down glucagon. Now, when you're in a fasted state, there's no glucose, excess glucose in the bloodstream. You have your right amount. You haven't eaten, so no insulin needs to come out. Nothing is going to tell the glucagon cells to stop. So glucagon can now come out when you're fasted to raise your blood sugar. But when you've eaten and you have insulin coming out, it shuts off the glucagon so the insulin can get put into the bloodstream. And when insulin drops, you don't have anything, you don't eat anymore, then glucagon will eventually be able to come out and raise your sugar as you need to. So that's why it's important. Insulin secreted from the core outwards, and so that alpha cells will receive high doses of insulin, and they're antagonistic to each other, so that insulin will shut off the glucagon. So, insulin. When insulin is formed, it's a proinsulin. Again, it's the inactive form. It's got the word pro in front of it. Now, there are three parts to a insulin molecule. It's right there. We have the proinsulin. We have the whole part. The red is this C-peptide. When you turn proinsulin to insulin, you cleave that C-peptide. So for every 1 unit of insulin that my body makes, what am I also making 1 unit of? C-peptide. So if I drew your blood, I should see insulin and I should also see C-peptide. That means if I see C-peptide in your blood, the only way you can get it is by you making your own insulin. Okay? Type 1s, diabetics, they do not make any insulin at all anymore. Will a type 1 diabetic have any C-peptide in their blood? No, because they're taking regular, already formed insulin via a needle. There's no reason, it's not pro-insulin, they're getting insulin. There's no C-peptide. So that's one of the clues you can see if you see blood report. Oh, this patient has insulin, but there's no C-peptide. They must be taking insulin exogenously because there's no C-peptide. Okay, so that's how you get insulin and C-peptide. They're joined to make a proinsulin. You cleave it, C-peptide gets released, and insulin, one-to-one, they all get released. And I just talked about that. Okay, what are the actions of insulin? After a meal, it comes out and returns to baseline between meals. Directs fuel metabolism towards use of carbohydrates to prevent increases in blood glucose. The net direct is reduction in glucose, amino acids, fatty acids, and keto acids. As long as you have insulin floating around your system, you really shouldn't go into any type of diabetic ketoacidosis because the insulin is still there to prevent keto acid production. When you don't have any more insulin, that's why type 1s get a lot of diabetic ketoacidosis because they don't have any insulin floating around to prevent the keto acid buildup or the use of ketones for energy source. As long as you have insulin, you're going to use carbohydrates. So that's what insulin does. So, liver, increased metabolism of glucose as fuel, stored the glucose as glycogen, so we're taking it out of the blood, it's going into the liver, it's out of the blood. Conversion of glucose to trigs. That's how you gain weight eating carbohydrates and you're not exercising to burn it off. All that excess carbohydrate, insulin's going to turn it into trigs, and now it's fat. And now you have a lot more trouble getting rid of it. And stimulates hepatic protein synthesis and inhibits protein breakdown. So again, building protein. That's going to make you big, right? What does growth hormone cause the release of? Growth hormone causes what? Insulin-like growth factor 1 to come out, right? That's the first thing it does. Then the other effects happen. Growth hormone causes you to build up muscle. Insulin causes you to build protein, keep glucose out of the bloodstream. Skeletal muscle stimulates glucose uptake into muscles via GLUT4. Skeletal muscle is unique in that after exercise, these GLUT4 transporters will work on their own without insulin. That's why exercise is very important for type 1s. It helps get rid of the glucose. If you are a type 1 or you know someone who's type 1 and they're on insulin and they're going to go exercise, what do you think they should do to their insulin before they work out? Increase it, lower it, or keep it the same? Decrease it. Why? Because after they exercise, the muscle will take all the extra glucose by itself and put it in the muscle. You don't need the insulin. If you take insulin, you're going to bottom out and cause hypoglycemia because now you have two ways of putting glucose into the muscle, insulin and post-exercise. And increases glycogen synthesis in the muscle. So we have all this stored glucose. We store it as glycogen in the liver and the muscle. In the adipose tissue, it also stimulates glucose uptake via GLUT4, and obviously we're going to store all these glucose as trigs, and now we've converted a carbohydrate to a fat. And you gain weight just by eating carbs. That's why carbs are bad for you. Only in certain proportions, you don't eat a whole lot. I already talked about that. Okay. Other things, we talked about this. It was on your exam today as well. Insulin drives potassium into the cell. Okay, that's one of the things. So most meals contain a lot of potassium, which must be sequestered into cells to prevent all these increases in potassium. Insulin helps to do that. All that extra potassium you ate. Bananas don't have any extra potassium in it. It's all made up. It's not like, there's nothing really into that. I also hear about the whole spinach and iron thing. They moved the decimal point over too many spots, and that's why it's inflated. You think it's all this iron and spinach. It's not. It's just a mathematical problem. There's not a lot of iron in spinach. So one of the jobs of insulin is not only just glucose, it's also going to help with potassium, getting rid of the potassium. Okay. Tyrosine kinase is the receptor. It's not a secondary messenger system. We mentioned these are the extra ones. Tyrosine kinase is one of the extra ones, and it's for insulin. The number of available insulin receptors is important about your response to insulin. In obesity, the expression of insulin receptors are reduced. So you are going to become insulin resistant with obesity. That's how obesity leads to diabetes. You make your cells less responsive to insulin, so more glucose hangs out in the bloodstream. We have to get rid of this extra bloodstream, so how do we do it? We make more insulin. Over time, these type 2 diabetics with this obesity, over time, many, many years of uncontrolled glucose, I mean, they're eating like garbage, they're not exercising, they're gaining all this weight. Eventually, those beta cells in the islets of Langerhans get burnt out, and they stop making insulin. And eventually, a type 2 diabetic will become insulin dependent. And if you ever see a type 2 diabetic who's on insulin, that means that their beta cells have already started getting burnt out. Your body can't produce the insulin needed, so you have to take extra. Because you've worn out your beta cells, the tissues aren't responding to the insulin. Your body can make insulin, your tissues aren't going to react to it. And that's what obesity starts that whole cascade up. Control of insulin secretion. What happens here, which goes to this picture, we have glucose in the blood. This is a beta cell. So it's that light blue color. There's hundreds of these inside that little islet. This is the beta cell. So each beta cell have these GLUT2 carriers that are going to sense the amount of glucose floating around in the bloodstream. The more glucose, the more these beta cells are going to be activated with glucose. So this glucose comes in, goes into the mitochondria, and it starts making ATP. That's what's supposed to happen. This ATP causes an ATP-sensitive potassium channel to open up. It causes depolarization to occur, which then causes our voltage-gated channel for calcium to open up. We know what calcium does from here, exocytosis, and there we get our insulin release. Okay, so how do we get insulin out? Glucose will actually touch the cell, causing insulin to be released. So it's not just like we're just, hypothalamus is just, this is where our glucose is. No, our islets of Langerhans will actually sense every molecule of glucose coming through it to release insulin along with it. That's how you get insulin out of the beta cell. Control of insulin secretion. Insulin is secreted in response to a meal before glucose is absorbed by the intestine. Hormones act slowly. If you ate something and then the stimulus for insulin secretion occurs, it wouldn't happen for a while. When we first get food or we start smelling food, we went through all those different activations. One of them was the GIP, I believe. That stimulates insulin secretion to start going. But that's a response from the duodenum or even from the stomach. Food hasn't gone into the intestine yet to be absorbed, but insulin is already starting to be built up so that when all that glucose does go into the bloodstream, your insulin is already there waiting to get all the glucose out of your bloodstream into your muscle or the liver or wherever it's got to go. So anticipation of a meal, weak stimulation of our beta cells. When food hits the small intestine, we get secretion of incretins. These are GI peptide hormones that stimulate insulin secretion. Major incretins, yep, so your glucose-dependent insulinotropic peptide, GIP, and your GLP-1. Okay, so these two drugs help get insulin going. Okay, incretins allow an increase in plasma insulin concentration. It gets things going before the food even hits the small intestine, so that when you absorb the glucose, your insulin's ready to go. Okay, so two classes of drugs are based off of these incretins. We have incretin mimetics. This is a GLP-1 agonist. And there's another one there too, but just know we can alter these incretins to alter your insulin response. And insulin secretion gradually declines as blood glucose decreases. There's less glucose activating those beta cells, less insulin coming out. Yes?
I thought the glucose has to bind to the cell first for insulin.
It does for insulin, but this is another way to get it out as well. These two hormones will stimulate insulin by itself in preparation for.
So it's happening like already without the glucose, and then when you eat, it also happens.
Uh-huh.
Okay.
We get active inhibition of insulin secretion during stress response. Makes sense. You want the glucose in the bloodstream to go to all your tissues that need energy. If you had insulin come out while you're exercising, you wouldn't have any glucose or enough glucose to feed your muscles. You would tire out way too fast, fatigue out, and you couldn't do anything. So we don't want insulin going around while we are exercising. So catecholamines are going to inhibit insulin. Okay, don't worry about the rest of it. Just catecholamines are going to reduce the insulin so that all the blood glucose can go to all the muscles that need work. So that's insulin. Let's talk about glucagon now, which is the opposite. So it antagonizes the action of insulin to increase blood glucose concentration, and it's in the alpha cells, in the islets of Langerhans, also in the L cells in the intestinal mucosa, and these L cells mainly produce GLP-1. Main target for glucagon is the liver. It's going to start breaking down that glycogen into glucose and dumping that glucose into the bloodstream, so it's ready to go. And glycogenolysis, what's that? Breakdown of glycogen. Gluconeogenesis, new glucose from amino acids usually. The major ketones are beta-hydroxybutyrate and acetoacidic acid. And these are synthesized from fatty acids via acetylcoenzyme A. Ketones provide an alternative energy source. So you can only have ketone formation when you are fasting. And mainly, no carbohydrates. You don't want the glucose. Once you get glucose in the system, insulin's going to come out, and the whole system goes to put. You got to start over again. So use of ketones for fuel conserves glucose and cellular protein stores as fasting progresses to starvation. So these long fasts, 48-hour fasts over a certain period of time. That's why people who do like intermittent fasting or they do Atkins diet where they don't have any carbohydrates at all, they produce a lot of ketones. So their breath starts to smell different. Because of the ketones, we have to exhale it. It gives a fruity acetone smell to it. So people who are ketosis will have some weird breath smells. High concentrations of glucagon, especially during starvation, stimulate lipolysis in adipose tissue. What's going to happen to your adipose tissue? Is it going to go down or go up? Down. You lose weight. Adipose cells don't divide. They just get bigger and smaller. In like morbid obesity, like 600-pound life people, those adipose cells, they actually can divide in like morbid obesity. But in normal individuals, it's just the cells get bigger and you look like you gain weight, or the fat cells get smaller and you look like you lost weight. That's pretty much all that happens with adipose cells. So glucagon causes adipose tissue to start undergoing lipolysis, and you're going to start breaking down that fat. and proteolysis in muscle to maintain a supply of substrates. What is that going to do to your muscle mass? Decrease it. That's why with long-term starvation, eventually you get muscle wasting because you need to break down that protein to provide more glucose because you need to do gluconeogenesis. Which is, again, if you ever do like intermittent fasting, the protein is the key. As long as you have enough protein, you won't lose your muscle mass. If you don't have enough protein, you'll start losing muscle mass. Control of secretion is obviously opposite of insulin. Why? We talked about it before. The way the blood supply goes, that insulin bathes over the glucagon cells, turning them off. When you're in a period of fasting, there's no insulin release, so glucagon can just be released with no effects. Nothing is turning it off. Ingestion of a protein-rich meal will stimulate glucagon secretion as well. So high-protein meals. That is why also, if you are a diabetic and you have hypoglycemia, where you start getting sweaty and everything, you can't have any protein because it slows the absorption. You won't get the glucose in as fast. So you have to take straight sugar, which will go in your system faster to bring your glycemic levels back up. Protein won't do it. It's too slow. So why is it important that glucagon gets released with protein? Because the amino acids that are released and absorbed by the GI system, when you hydrolyze, that was also in your exam today, digestion, right? Hydrolyzing the macros into smaller micronutrients. All this amino acids get blown into the bloodstream as well, can also stimulate insulin secretion. So by having glucagon come out, it prevents that initial insulin. So this development prevents hypoglycemia due to an excess of insulin. So with protein-rich meals, glucagon will come out as well. That's why it's so important to have protein, especially for diabetics, protein with every meal. You gotta have protein. Helps with the sugar. So our glucose concentration is off of what we eat and what we can get rid of. We learned in the renal system that eventually all those transport mechanisms to bring glucose back into the bloodstream get maxed out at some point. Then we start having what? Glucose in the urine because we have too much of it. So that is the elimination of it. We can't eliminate it anymore. You're still eating all the garbage food. That glucose is going to start building up in your bloodstream. Input dependent, again, on diet and what the liver is producing. Liver does gluconeogenesis. It's going to kick in some more glucose. And the output is a function of tissue metabolism. Decreased metabolic use of glucose and increased hepatic production of glucose with hypoglycemia resulted in an interplay between different hormones. The first response, glucagon and catecholamines rapidly act to counter any hypoglycemia or hyperglycemia. Oh, hypo, I'm sorry. Who's had a hypoglycemic event? I don't want to call you out, but if you want to. You want to talk? You okay? Yeah. Okay. So what kind of symptoms do you get when you get a hypo event?
I actually start sweating. I get shaky. I've never passed out from it, but if I get low enough, you can pass out. And then just like brain fog.
So what are the first symptoms you talked about? And shaking, right? What's released for those immediate responses to hypoglycemia? Catecholamines. So if you have a hypo event, the first response is your sympathetic nervous system kicking in. Heart rate goes up, you get jittery, sweating because your sympathetic system is kicking in to try and combat the hypoglycemia. That is a rapid response. In a sustained response, usually due to like fasting for a long period of time, cortisol and growth hormones start to have a bigger role, with these long-term fastings when you become hypo. But short-term, you dropped glucose too fast, the first response is your sympathetic nervous system kicking in catecholamines and the glucagon. But the catecholamines gives you that jitteriness, the heart rate going up faster, and whatnot. This you can do on your own. It's a good review talking about actions of insulin and glucagon. The last thing we're talking about, we'll be done, is parathyroid hormone, vitamin D, and calcitonin, all dealing with calcium. PTH and vitamin D are the principal hormones that regulate calcium and phosphate homeostasis. PTH is secreted from the chief cells of the thyroid, or really the parathyroid gland. How many parathyroids are there? 4, 1 in each lobe. So there's 4 parathyroids. If you're seeing a patient who's had a thyroidectomy, you better find out, do they still have their parathyroid glands? Usually they leave them there, or they'll take them out and like put them in like your forearm or something. Your parathyroid. It doesn't matter where they are. Only they have blood supply, they can figure it out and they'll work. So they go anywhere. But things to keep in mind: surgical history, thyroid. Do you still have your parathyroids? I mentioned like the gastric bypass. What kind did you have? Do you still have your terminal ileum? Find these questions out when you're doing your history. Anesthesiology, you guys still got to do a history on your patients before you anesthetize them, so you better find out all these things, especially thyroid, because you can get malignant hypertension with induction of anesthesia. So a lot of things to watch out for. Homeostasis of calcium and phosphate are linked because they're mainly in the bone. When we talk about the urine, the body doesn't care about the urine concentration. It's similar to the bone itself as well. The body doesn't care about the bone. The body cares about the calcium level in the blood. The bone has a ton of calcium and phosphate in it. So guess what our body does if we need calcium? We leach the bone. We break down the bone, dump calcium into the bloodstream. When we have too much calcium, we dump it into the bone. That's why people take calcium supplements to overload the calcium so that they deposit that extra calcium into the bone, strengthening the bone. So, structural component of the bone, muscle excitation, exocytosis, signaling, and so forth. Phosphate is also a component of the bone, and also in all the cells, and needed for energy metabolism. So again, balance between the input, what are you eating, and what are you taking out of your circulation. Obviously, calcium is going to enter through the GI tract and from the bone. That's how we can get calcium. Renal excretion and bone formation remove calcium. We already learned about the renal excretion, now I'm just talking about the bone. If you have extra calcium, you throw it in the bone. Bone is constantly being remodeled via osteoblast. B, they build bone. Osteoclast, they destroy bone. So these two things are constantly going. We're constantly removing calcium. We're constantly putting calcium back in, all to maintain homeostasis for calcium levels. And the balance between all these affects your calcium and phosphate levels. So calcium, 3 forms in the blood. 45% is free ionized calcium, 4 to 5.2. 45% is bound to plasma proteins. So we learned before, if you have liver failure, you don't have that many plasma proteins anymore. What number is going to go up? Your free calcium is going to go up, because less calcium is going to be bound to the proteins, which you don't have anymore. So it's going to be floating around in the blood. So the free calcium goes up. And 10% is complex with low molecular weight anions, citrate and oxalate. These are your kidney stones. Calcium oxalate, calcium citrate. You have too much calcium in the urine, it can precipitate out into a stone. It's like if you're making coffee and you keep putting sugar in it, Eventually, that coffee can't hold any more sugar in it, and the sugar results on the bottom of the cup because it can't get into solution because you've already saturated that coffee with sugar. Same thing with like the urine. You have too much calcium, it supersaturates it, crystallizes out, you get a kidney stone, and all that fun stuff. Phosphate has two major forms. 80% is alkaline phosphatase, HPO4 2-, which is at a normal pH of 7.4, and 20% as this acid phosphatase. That's one of our titratable acids, so we can add a hydrogen to it, dump it in the urine, we can get rid of acid that way. So the plasma phosphate range is 2,5 to 4,5. Don't worry about this one. I won't confuse you guys more with acid-based stuff. Okay, PTH. PTH is what exerts the dominant control over calcium and phosphate homeostasis. That's the main job of PTH. Two on each lobe, on the back of the thyroid. What are the actions? Stimulate bone resorption. We're going to break down the bone. It's going to dump calcium and phosphate into the blood, back in the plasma. PTH will also decrease renal calcium excretion. So we're not going to lose calcium in the urine anymore. We're going to bring it back into the plasma. So we get reabsorption of calcium, thick ascending limb, and distal tubule. What it also does is it increases renal phosphate excretion. Why is that important? What is the purpose of the PTH coming out? What's the stimulus? It's calcium levels, right? All we worry about is the calcium levels. When PTH comes out and it breaks down the bone, what two ions come out? Calcium and the phosphate. We don't want that phosphate floating around. We only need the calcium. So PTH will also help you get rid of that excess phosphate that you have now accumulated from breaking down that bone. So PTH kind of helps the phosphate get rid of it because it's a consequence of bone breakdown, but we don't need that phosphate. So PTH will also allow the kidneys to get rid of it, getting it out of the blood. So the net effect of PTH on calcium, increase in plasma calcium concentration. The net effect of PTH on phosphate is reduced plasma phosphate concentration. Okay, the phosphate is a consequence of the breakdown of the bone, but we don't want it, so we get rid of it in the urine, and the PTH does that as well. So the control of PTH secretion has to deal with concentration of calcium. Decrease in calcium is the most potent stimulator for PTH secretion. Okay. If plasma phosphate goes up for some reason, that will also cause PTH to come out, to get rid of that phosphate we don't need. Vitamin D is very important. PTH will stimulate vitamin D synthesis, which eventually will cause a negative feedback on PTH secretion. We need negative feedbacks for control. If PTH just kept going, what's going to happen to your bone? It's going to get weaker and weaker and weaker. So we need to have a way to shut it off. So when PTH gets activated, it also activates vitamin D, which is going to allow your calcium levels to go up. So vitamin D and PTH are like opposite sides. PTH will raise your calcium, vitamin D will take it out. What does vitamin D do? Okay, vitamin D2 and vitamin D3. D3 is the precursor molecule. And where is it made from? Liver. Makes a little bit of vitamin D, not much, but it can make the inactive form. And then it gets activated by the kidneys, right? That's one of the endocrine functions of the kidneys, activation of vitamin D. So vitamin D can also be synthesized from UV light. That's why staying outside is important. Getting some sunlight helps with vitamin D production on its own. And it gets stored in adipose cells if circulating levels of vitamin D3 decrease. Activation occurs in the kidney. Again, if they have chronic renal failure, they have deficient vitamin D. So, what does vitamin D do? Stimulation of dietary calcium and phosphate absorption in the small intestine. That's what vitamin D does. That's why if anyone takes a calcium supplement, they should take vitamin D with it, because the vitamin D is going to allow your small intestine to absorb that dietary calcium easier to raise your calcium levels in the blood. So that's one effect that vitamin D does. So causes calcium and phosphate ions to increase in the plasma. And like I said, when you have excess calcium and phosphate, we're going to dump it into the bone. So if you have osteoporosis, you get calcium and vitamin D in the hopes that we overload your blood with calcium, so it has to go into the bone to strengthen the bones. And that's what vitamin D does. The last one is calcitonin. Calcitonin is very, very, very weak. Doesn't really do much. We don't really worry about it when it comes to calcium homeostasis. But it's an important marker sometimes for cancer, especially like thyroid cancer. So in humans, calcitonin, very weak effect on calcium homeostasis, and neither the absence or excess of calcitonin will cause any really major defects in calcium or phosphate levels in the blood. But it's a marker for medullary thyroid cancer. And when we talk about hypercalcemia and different types of diseases, we look at calcitonin levels. But it really doesn't do much with regards to calcium per se. This is, again, a summary chart. Great looking at PTH versus vitamin D. I'll let you guys do that on your own. Sex steroids and bones. Estradiol in the females and testosterone in males are required for constant bone maintenance and bone mass. In postmenopausal women, they lose estrogen. Okay, they're not going to make estrogen anymore, which is why osteoporosis occurs in postmenopausal women because of the alterations in the bone mass due to the lack of estrogen, which is why postmenopausal women will go on hormone replacement therapy, get the estrogen back in to help their bone mass. Estrogen is also very cardioprotective as well. That's why women will live longer. They won't get heart attacks until later in life because of the estrogen. Osteoporosis, less common in males due to less decline in testosterone. Weight has a lot to do with it too. These frail old ladies, there's no weight they're putting on their bones. They get very, very weak. When you have obesity or weight, it's called Wolff's Law. The more stress you put on your bones, the stronger they become. So in elderly, it's very important they weight train. It protects their bones from getting weak and breaking. This last little bit is going to be fast because we're going to do the majority of it when we get to reproductive. So the endocrine axis, sex steroids, obviously differentiation and maintenance of gonads and other reproductive organs. Sex steroids is under hierarchical control, pituitary hypothalamic factors. Why? What hormones are we talking about now? Sex steroids. FSH and LH. Okay? Starts at the hypothalamus. What does the hypothalamus release? Gonadotropin releasing hormone, GnRH, which will then go to the pituitary gland to release your FSH and your LH. That's why it's under hierarchical control from the hypothalamus pituitary gland, because they're both used in releasing those hormones. Steroid synthesis in the ovaries and testes produce different products than the adrenal glands. Why? Because they have different enzymes. Gonads don't have 21 alpha hydroxylase or the 11 beta hydroxylase. The 21 is important. Why is the 21 alpha hydroxylase important? For which ones? Cortisol and aldosterone. So in the adrenal glands, they produce very weak androgens. In the testes and ovaries, they're going to produce very strong ones. Most of it is because they don't have the enzymes. So there are 3 classes of steroids produced by the gonads. 1, progestins. These are your progesterones, primarily female sex steroids. This helps get the uterine lining ready for pregnancy. And we'll talk about this in great detail on Thursday next week. Estrogens, estradiol, major role in puberty in girls and the menstrual cycle. And we finally have androgens, which is our testosterone, major sex steroid in males, produced by the Leydig cells in the testes, and it's a major thing with sex differentiation. We'll talk about this when we come to embryology, when we talk about reproductive, but it's testes determining factor. If it's present, you turn into a male. If it's not, you stay a female. Okay. Here is our chart again. And because we don't have these things in the testes or ovaries, everything gets converted to all that stuff. Don't need to worry about everything else. Just know they don't have the enzyme. Can't make any cortisol. You can't make aldosterone. So all these products all go towards your sex steroids. Let's see where we're at here. Yeah, we're done here in 2 slides. Okay. Under control of luteinizing hormone and FSH. We also know GnRH is there as well. GnRH secretion is pulsatile. So it's constantly stimulating those gonadotropes to release more FSH, more LH, but it's pulsatile. If secretion is constant, this is why, again, we don't like constant release of hormones. Cells become desensitized and they won't secrete LH and FSH anymore. So pulsatile secretions provide better results. We don't desensitize the cells. We don't downregulate them. HCG, human chorionic gonadotropin, is pregnancy-specific, secreted by the developing placenta, and necessary to maintain ovarian steroid production early in pregnancy. We'll talk about the placenta, what it does when we get to all that stuff about pregnancy. Here is your box that you got to know. Here's the different thing about this one. We'll get to it in a second. Hypothalamus, here's your GnRH. Goes to the anterior pituitary to release LH and FSH. FSH, follicle stimulating hormone. So what do you think it does in females? Stimulates a follicle. It's like make an egg. Men don't have eggs. What do men have? Sperm. So FSH in male will make sperm. This spermatogenesis causes inhibin to be released. This inhibin by itself has a negative feedback at the anterior pituitary. This is special with FSH. It has this inhibin there, which will turn off the anterior pituitary from making FSH. Now we have the luteinizing hormone. Luteinizing hormone in males stimulates the Leydig cells to make testosterone. So luteinizing hormone in males, testosterone, FSH in males, spermatogenesis. The testosterone has negative feedbacks at the anterior pituitary and the hypothalamus. So it keeps your testosterone levels in check so they don't go crazy. And we're going to deal with a lot more in chapter 9 next week. The axis for females is more complex than males due to the changes in the ovarian cycle. There's variable control of the gonadotropes by positive and negative feedback, but obviously this is all going to be in chapter 9. And we are done. So I'll see you guys on Thursday.